Start again.
Good morning, everyone. And today's medicine class is about medical emergency and paracetamol poisoning. Coming to introduction, paracetamol is also known as acetaminophen or N-acetyl-P-aminophenol. It is a diethylated active metabolite of phenacetin discovered in 1877, which was used as an analgesic and antipyretic. By 1963, paracetamol was available worldwide as an over-the-counter drug. Coming to actions, the main mechanism proposed is the inhibition of cyclooxygenase, and recent findings suggest that it is highly selective for COX-2 also. By inhibition of COX, it prevents generation of prostaglandins from the arachidonic acid, which are in turn converted to numerous other pro-inflammatory mediators. And by central subcortical action, raising the pain threshold, it raises pain threshold, acts as an analgesic. Mechanism of toxicity. A small proportion of acetaminophen is metabolized by a phase 1 reaction to a hepatotoxic metabolite formed from the parent compound by the cytochrome P50, that is CYP2E1, and this metabolite, like N-acetyl parabenzoquinone, is detoxified by binding to hepatoprotective glutathione to become harmless. Water-soluble mercapturic acid, which undergoes renal excretion. When excessive amounts of NAPQ are formed, glutathione levels are depleted and overwhelmed, permitting a covalent binding to nucleophilic hepatocyte macromolecules, forming acetaminophen protein adducts. The binding of acetaminophen to hepatocyte macromolecules is believed to lead to centrolobular hepatic necrosis. Even in the absence of hepatotoxicity, renal failure can occur because of renal papillary necrosis. This is the normal picture, and this is the centrolobular necrosis. Coming to clinical features, this includes 4 phases, and the first phase includes anorexia, nausea, vomiting, and phase 2 it includes right upper quadrant pain and elevated liver enzymes, PTINR, and PTINR are elevated. Coming to phase 3, vomiting, symptoms of liver failure, renal failure, and pancreatitis may occur. And coming to phase 4, that is more than 4 days, resolution of symptoms are progressed to fatality. Dose ingestion is minimum toxic dose for single ingestion is adults 7.5 to 10 grams and children 150 milligrams per kg, that is 200 milligrams kg in healthy, and children aged 1 to 6 years. Fatal dose is 20 to 25 grams and fatal period is 2 to 4 days. Investigations, like we do serum acetaminophen concentration and liver function tests like ALT, AST, and direct bilirubin, indirect bilirubin, alkaline phosphatase, prothrombin time in international normalized ratio, and RBS and renal function tests, electrolytes, blood urine nitrogen, creatinine. And also like lipase and amylase, if there is complaints of abdominal pain, and arterial blood gas analysis and pneumonia, urine analysis for hematuria and proteinuria, and ECG to detect additional clues for co-ingestions, and CT brain if there is altered sensorium. This is the time of investigations. Recommended investigations according to time for paracetamol ingestion and for N-acetyl treatment. And test we doing is serum paracetamol, that is time between 1 to 8 hours at 4 hours or as soon as thereafter as possible, or 8 to 24 hours on admission and 24 hours on admission. We look for all these investigations like ALT, AST, INR, creatinine, urea, glucose, and arterial blood gas analysis. Blood levels of acetaminophen correlate with severity of hepatic injury. Like we correlate the severity of hepatic injury when the levels are more than 300 micrograms for 4 hours after ingestion are predictive for the development of severe damage, and levels less than 150 suggest that hepatic injury is highly unlikely. And clinical suspicion of acetaminophen hepatotoxicity should be raised by the presence of the extremely high aminotransferase levels in association with low bilirubin levels that are characteristic of this hyperacute injury. Coming to management, that there are no early symptoms that predict acetaminophen toxicity. Poisoning severity following on an acute ingestion is quantified by plotted time serum acetaminophen concentration on the modified Rumack-Matthew nomogram, drawn not less than 4 hours after ingestion. Serves as a guide for management. Rumack-Matthew nomogram is used to interpret serum acetaminophen concentrations in relation to time since ingestion, and in order to assess potential hepatotoxicity. The nomogram predicts the risk of hepatotoxicity on a single acetaminophen concentration measured at one time. It is not a prognostic tool and hence does not predict fulminant hepatic failure or death. The nomogram predicts potential toxicity beginning at 4 hours after ingestion up to 24 hours after ingestion. Acetaminophen concentration measured earlier than the 4 hours post ingestion may not be reliable. This is a nomogram showing here. Treatment includes gastric lavage, supportive measures, and oral administration of activated charcoal or cholestyramine to prevent absorption of residual drug. Treatment with activated charcoal, that is 1 gram per kg, that maximum dose can be given 50 grams by mouth in all patients who present within 4 hours of a known or suspected acetaminophen. Antidote like N-acetylcysteine is the accepted antidote for acetaminophen poisoning. Serious hepatotoxicity is uncommon and death extremely rare if N-acetylcysteine is administered within 8 hours following acetaminophen overdose. The key to effective treatment is to start therapy before the onset of liver injury, which can be defined biochemically by elevation of phenylalanine aminotransferase. Indications for N-acetylcysteine therapy. A suspected single ingestion of greater than 150 mg per kg, that is 7.5 gram total dose regardless of weight, in a patient for whom the serum acetaminophen concentration will not be available until more than 8 hours from the time of ingestion. Patient with unknown time of ingestion and a serum acetaminophen concentration more than 10 micrograms, and patient with history of ingestion and evidence of any liver injury, and patients with delayed presentation, that is more than 24 hours after ingestion, consisting a laboratory evidence of liver injury ranging from mildly elevated aminotransferase to fulminant hepatic failure. The common protocols are 20-hour IV protocol. The approved 20-hour IV dosing regime is complicated and is performed as follows. 150 mg per kg in 200 ml of D5, that is dextrose 5W infused over 1 hour, followed by 50 mg in 500 ml of D5 over 4 hours, and then 100 mg in 1000 ml of dextrose over 16 hours. 72-hour protocol, a loading dose of 140 mg kg per oral, followed by 70 mg per oral every 4 hours for a total of 17 doses. The incidence of hepatotoxicity for patients treated within 8 hours of ingestion is less than 10%, but increases to approximately 40% if treatment is delayed beyond 16 hours. In most patients, either the oral or IV route is acceptable. IV administration is favored for patients with any of the following: like vomiting, contraindications to oral administration, that is pancreatitis, bowel ileus, obstruction and bowel injury, hepatic failure, patients who refuse oral administration, and patients with evidence of hepatic failure. N-acetylcysteine adverse effects, like these are non-IgE mediated anaphylaxis with intravenous administration, vomiting with oral administration. Patients receiving IV N-acetylcysteine warrant close monitoring, and all essential medications and tools needed to treat anaphylaxis and airway emergency should be immediately available. These include oxygen, antihistamine medication like diphenhydramine and ranitidine, albuterol, epinephrine, that is 1:1000 for intramuscular use. Methionine, this is another drug. Alternative antidote is methionine, that is 2.5 gram orally adult dose for every 4 hours to a total of 4 doses up to a total of 10 grams orally. But this is less effective, especially after delayed presentation. And do not give activated charcoal as it will bind to methionine. It acts by increasing glutathione synthesis. And finally, liver transplantation is a sign of hepatic failure, that is progressive jaundice, coagulopathy, confusion occur despite N-acetylcysteine therapy for acetaminophen hepatotoxicity. Liver transplantation may be the only option. The United Kingdom King's College Hospital criteria for the determination of the urgent need for transplantation of acetaminophen-induced fulminant hepatic failure include any of these following: that is arterial pH less than 7.3 after fluid resuscitation, and lactate levels more than 3.5 millimoles per liter, and grade 3 or grade 4 encephalopathy, and prothrombin greater than 100 seconds, serum creatinine greater than 3.4 milligram per deciliter. And conclusion, because of the limited safety margin between the safe and toxic doses, the FDA has recommended that this daily dose of acetaminophen be reduced from 4 gram to 3 gram, even lower for persons with chronic alcoholic use. that all acetaminophen containing products be labeled predominantly as containing acetaminophen, and that the potential for liver injury be prominent in the packaging of acetaminophen and acetaminophen containing products. Within opioid combination products, the limit for the acetaminophen component has been lowered to 325 mg per tablet. And these are the references. Thank you.